A very good evening to everybody. I welcome you all to this webinar by Tahoe Diagnostic Division. The topic for today's webinar is setting up an IHC lab, basics and quality aspects. Welcome you all. Can you go to the next slide? Yeah, I am moderator Dr. Zubair Hasan. And first, a little bit about the topic, because we have a stalwart here who will be explaining in much detail. I will not take much time. So what is IHC? Many times we pathologists sign out reports, and it will be just a small round cell tumor or a malignant neoplasm, query carcinoma, query lymphoma. That is the time we realize that there is something beyond the light microscopy we would like to utilize, and that is the immunohistochemistry. And this topic began over 120 years ago by von Behring, who discovered serum antibodies in the year 1890 to cure diphtheria and tetanus, and Dr. Albert H. Kunz developed the first fluorescent antibody labels, officially launching the light in microscopic immunohistochemistry in 1941. So there are a lot of applications of IHC, which our esteemed speaker will speak today. Mainly it's in prognostic markers in cancer, tumors of uncertain histogenesis, prediction of response to therapy, infections, genetics, neurodegenerative disorders, brain trauma, IHC in muscle disease, and research applications. Can we go to the next slide, please? It's my honor and privilege to introduce Dr. Vidya, whom I have known from over a decade at this August forum. Next slide, please. Yeah. So Dr. Vidya, she's current affiliated as a lead consultant in histopathology at Manipal Hospitals, Old Airport Road, Bangalore. Her past affiliations are: she was the lead consultant of histopathology and cytopathology at Aster Reference Lab, Bangalore. Previous to that, she was the HOD of histopathology and cytopathology at Anand Diagnostic Laboratory, Bangalore, registrar of pathology at Apollo Hospitals, Bangalore, with additional trainings of basic training in molecular pathology at 2015 session of CMC Vellore, and she's a Targo certified pathologist for reporting of PDL1. Awarded the best paper presentation at Capcom 2012, and she has numerous publications to her credit, and member of DSI, IAC, IAPM, former executive committee member of KCIPM, a resource person for various workshops, moderator for annual PG training and teaching programs, faculty at national and state level CMEs and conferences.
Move on to the topic. Yeah. So why is immunohistochemistry required? Earlier, most of us are definitely histomorphologists and we like going back and seeing our H&E slides. But over the last 2-3 decades, there has been a vast improvement and the need has arisen for more than a histomorphological diagnosis, where we are entering the era of molecular diagnostics as well. So here IHC is actually bridging the gap between molecular lab to the histopathology lab, wherein we have a lot of molecular surrogates that are available in the form of immunohistochemistry. So IHC is required for various diagnostic purposes, where the pathologist will raise the request for IHC to see what kind of a tumor it is. And theranostic, I would say, is therapeutic dictation. So basically the pathologist here, with the help of IHC, is aiding the treatment of the patient. For example, the most common thing that we come across is breast cancers. These days, you know that even FNACs have been stopped, and it is predominantly core needle biopsy that we get. And the patients are put on various treatment based on the IHC results of the hormone markers. So these are few therapeutic indications. The others are like your upcoming biomarkers, like your PDL1, etc. So these again have a therapeutic indication, wherein the IHC results are dictating the terms of treatment for the patient, and this is where the pathologist has to be very accurate in what they are reporting in their lab. Prognostication of diseases, we know that for lymphomas we add a lot of markers which help in the prognosis of the disease and also the treatment part of it. So also for detection of infections, for example, your post transplant cases, like your SV14, your renal transplant biopsies, you have CMVs in as an opportunistic infection in various conditions. Then we also have few other infections which actually promote carcinogenesis, like for example your EBV. So these are few things that come into picture where we can detect infections with the help of immunohistochemistry markers. So this Starting an immunohistochemistry is not really difficult. This is going to provide comprehensive and complete service for a lab or a hospital, and it elevates the technical capability of the lab and as well as the pathologist who's doing the reporting, because these are considered as high-end tests, and then you are going to have a full circle in terms of the diagnosis as well as patient treatment. So there are a lot of I mean initial phases, maybe 10, 12 years back also it was very difficult, and most of the labs were just having some ERPR markers and also some proliferative markers and very few basic lymphoma markers like your CD3 or CD20. But now there are a lot of monoclonal antibodies which are coming into picture, which have increased the diagnostic specificity. And there are various mechanisms of antigen retrieval. It is no more, earlier people used to use soap detergents for antigen retrieval, and the various different buffers which were actually not of very good quality. But here heat induced epitope retrieval has come into picture, and which has actually been a game changer in terms of your antigen retrieval systems. And also we have very sensitive secondary antibody detection systems, which reduces the background noise, and also the specificity of your test increases. And also we have automated IHC platforms. We know of many IHC platforms which can cater to your high throughput labs as well as your low throughput labs. So this, along with definitely last but not the least, digital pathology with image analysis, has all led to reproducible and reliable assays on our IHCs. It is no more that, okay, I'm doubtful on what my IHC result is. A lab can definitely sign off a very confident and reliable IHC report. So these are few things. Now let us come to the principle and the basics of our IHC test. As we all know, immunohistochemistry is nothing but it is immune reaction, which is basically a chemical reaction that we are testing on the tissues. So that is the essential definition of your immunohistochemistry. So we are detecting an antigen antibody reaction on the tissue. So how do we do that? If there is an antigen presentation in your tumor tissue, we add a primary antibody to which a secondary antibody is again added, and this primary antibody is monoclonal and it is very specific to that particular target antigen. Whereas your secondary antibody helps in binding to the primary antibody, because we need a detection system to know whether there is a primary antigen antibody reaction or not. And these secondary antibodies are polyclonal and they have multiple arms, and this is where it binds not only with the primary antibody, but it is also going to help you in binding with the detection kit, which has a HRP polymer, and we have a colored substrate. So what does the HRP polymer do? It is going to cause precipitation of the pigment, and we finally see the end result as a brown precipitate under the microscope for the pathologist. So this is how essentially we are going to see a lot of blues and browns, because brown is the precipitate and it is an universal chromogen that all the labs employ. So we are seeing blue, which is nothing but your hematoxylin stained cells, because we finally need to localize where exactly this antigen antibody reaction has happened, and the counter stain is definitely hematoxylin. Instead of a blue and pink, you're going to see a blue and brown. That is how your IHC slide is going to appear under the microscope. Pre-analytical phase is something which is very, very, very crucial when it comes to performing your IHC tests in your labs. So you need to have a very good sample accession register, because you need to know what the sample fixation has started and what is the nature of your fixative that has been used. Ideally, the recommendation for any IHC test based on the nature of your tissue, whether it is a small biopsy or a resection specimen, is going to be between 6 to 72 hours. Anything below this and after this, the IHC results cannot really be accurate, and it needs to be taken with a pinch of salt on what we are reporting, whether we are reporting a false negative result or what. Tissue processing is another important step, because tissue processing directly affects the antigen expression in your cells. So this is where the lab needs to have good lab practices, wherein the tissue reagents are changed on a regular basis and good quality reagents are used, because finally at the end of the day we are looking at giving a beneficial report to the patient. Decalcification is something that is going to hinder the IHC results. So you need to validate your decalcified tissues also whenever you start your IHC test in your lab. It could be manual or your automated assays, but definitely please keep in mind that decalcification and decalcified tissues should be made as part of your validation protocols, because here we do not know which antibody is going to work, what is a assay optimization that we need to do specifically for these decalcified tissues. So here the results are also interpreted with caution based on the amount of decalcification or the number of days of decalcification that has gone into the tissue. So always it is better to include a disclaimer in our report saying that this IHC assay has, whether it has been validated or not validated on decalcified tissues. And also we need to put a comment telling that the results should be interpreted with cautions, as there can be a false negativity on decalcified specimens. Slide drying and incubation time and temperature are again equally important. An excessively dried slide will lead to unnecessary undue background artifacts, and also there is going to be false localization of the DAP precipitation. So generally what is recommended is overnight, that is 37 degrees incubation time, that is your baking time, or 56 to 60 degrees based on the melting temperature of your wax, which is used in your laboratory. And this has to be kept at least for an hour before the IHC test is done. This is a very important slide and I generally use it for most of my seminars. This was published in the year 2012 in Modern Pathology, which definitely shows you this is a nuclear stain. This is an ER stain, and you can see that the cold ischemic time, that is when the surgeon removes the tissue and when the tissue enters formalin, that is called as the cold ischemic time, the interval between that. And the quality of your IHC actually starts in your OTs and in your endoscopic biopsy rooms. So this is where you need to go further ahead and educate your surgeons, your endoscopists, and the OT staff, telling the importance and telling them that the tissue has to be immediately put in formalin. You can see here, this is a good expression of ER that you're seeing, but whereas a delay in fixation of 3 hours, 24 hours, and 48 hours, look at this 48 hours. A tissue that should express ER is not expressing ER at all. That means you're releasing a false negative report handling a tissue of this nature. Hence, your test request form should definitely have the mention of the cold ischemic time, which is appropriate in a good lab practice, or you can find out. And for labs which are in the hospital, the best thing is as soon as the specimen comes into your lab, if it is a small biopsy, it goes for immediate fixation, and a large biopsy definitely it needs 24 to 48 hours of fixation. But please make a note of it and see that serial slices are done by your pathologists or your registrars in the hospital. So these are some things that can be done in your premises. Look at this second image. This is of HER2 new. We can see a nice membrane staining out here, which could be a 2 plus. So this is of a fixation of about half an hour. But again, when we come to 3 hours, 24 hours, and 48 hours, depending on whether this has been a core needle biopsy or something. So here, overfixation itself can cause a false negative report. So underfixation, overfixation, both play a major part whenever you are interpreting your IHC results, and you need to be extremely careful. So small biopsies cannot go through overfixation, large biopsies cannot go through underfixation. This is some basic principle that all of you need to keep in mind when you're handling your IHC cases. How do you select your slides for IHC test? So once the slides are out, you have seen the histomorphology. For example, you know that it is an invasive carcinoma. So how do you select? You may have done about 20-30 blocks of your tumor case, right? In this, the appropriate block also needs to go for IHC test. So generally what you need to follow in your lab is that you need to avoid areas of necrosis and crush artifacts. These should not be taken, because we can have a lot of false positive interpretations whenever there are areas of necrosis. For example, like only DCIS component should not be used for your HER2 new testing result, because we know that HER2 is reported only on your invasive component. Poorly processed tumor is a definite no when you are doing your IHC test. You need to always take the well preserved areas for your IHC. And you need to avoid sections cut prior to 6 weeks. Please do not make a habit in your lab and cut multiple sections, even it may be for your control, always cut fresh sections. So if you are cutting sections for whatever reason, you need to see that these are maintained at 2 to 8 degrees and they're not frozen. So definitely when we take out our old archive blocks, maybe 5 years or 10 years behind, and check, we know that there is some loss of indigeneity. So we need to also mark areas which is inclusive of your benign tissue. So grossing itself is an art, definitely, and the your postgraduate students or your registrars have to be taught that always a tumor has to be sampled with your benign tissue, because we are looking at various internal controls as well, which I'll speak in my next few slides. So metastatic lymph node also can be selected if tumor is not well preserved, but this will be a definite hindrance when we are looking at our proliferative markers. So we always need to include a positive control and or negative control with every slide. So I'm going to talk a little more on positive control standardization in my next few slides. So please make note that positive control has to be there in each and every slide that you're dealing with for IHC. Look at this. This is an example of how your crush artifact looks on HND and the same crush artifact slide on your IHC staining. Here we really can't make out. Here we can see some membrane staining, but look at these areas. We do not really know whether we need to take them into account or not. So these are some artifacts that can be caused, and which we need to always see that it is not used and it does not cause any bias while you're reporting. This is an example of background staining. The necrosis areas definitely take up a lot of DAB staining. Here we cannot make out, and for an inexperienced eye, they may consider the presence of this DAB precipitate as a positive reaction, and we may release a false positive report in these cases. Slide preparation is another important aspect of your IHC lab. So whenever you're wanting to start IHC in your institution or organization, you need to know that there is going to be cost involved. So one of them is going to be your coated slides, which you can commercially procure, or you can make them in your own laboratory with the use of the reagents. So here you may have to do single coats or double coats if you're doing in your lab, but these must be validated before you actually put them into practice. So these are nothing but charge coated slides. So here, basically the positive charge on the slide is going to attract the negative charges of tissue proteins. Formalin fixation causes a lot of cross-linking of your proteins, and these are going to mask your antigens. So what we are trying to do with the slide preparation and taking them on coated slides is all for a step before your antigen retrieval, which is the most important step. So the entire procedure of your IHC is depicted in this picture. So here you have your slide. An ideal section is cut, which is of about 3 to 4 microns. Generally 4 microns is recommended sections on your coated slides. Then we need to deparaffinize or dewax, and then you add a peroxidase agent to block all your endogenous proteins that are there. This is basically to increase the signals and reduce the background noise. After this comes the step of antigen retrieval. So where you unmask the antigens so that they can effectively bind with the primary antibody that you're going to add. So these are going to be your nuclear antibodies, your cytoplasmic antibodies, or your membranous antibodies. Generally, the antigen retrieval for your nuclear antibodies is going to be is going to take a lot more effort when compared to your membranous stains. Then after your antigen retrieval, you're going to add the primary antibody, incubate this for some time. In between, you have buffer washes, and then you add the secondary antibody along with your substrate and your detection kit. So here you may also use some amplifiers which are provided by few of the vendors. So it depends again on whether you need to use these amplifiers which are going to enhance the antigen antibody reaction or not. Generally, the automated equipments also have a step of enhancement wherein they have few copper or zinc washes, which is going to enhance the reaction, and your brown precipitate is seen in a very clear manner. After this, the slides are counterstained with hematoxylin, and then they are submitted to the pathologist after cover slipping for evaluation. So the A little bit on the antigen retrieval methods. Now, these are the days of automated equipments. So, wherein the instrument has all the steps built in the instrument itself. But earlier, the antigen retrieval methods were like pressure cookers, your microwaves, and your water baths. Even now, I would recommend that when you are a starting lab, you could go slow instead of directly jumping to an automated equipment. You can go in for these antigen retrieval methods, which are can be used with just the help of a simple water bath or a commercially available pressure cooker. So here we keep in the buffers. The buffers generally used are EDTA or citrate buffers for your antigen retrieval. This again, mind you, depends on the kind of antibody that you are looking at. Some antibodies it is possible with EDTA, for some it is citrate buffers. So you need to carefully read the pack insert of your antibodies and adjust the pH. Calibrated pH meters are an important instrument that you need to procure when you are doing your manual IHCs. Otherwise, please remember, when there is a variation in your pH of your antigen retrieval buffer, it is going to further affect all the downstream processes and you may land up with a negative result. So the heat induced epitope retrieval is something which is there now, and for most of our antibodies. Other than this, we also have digestive enzymes, detergents, and pressure boiling. So heat-induced epitope retrieval is something that is being universally adopted in all our automated platforms also. So once you know that, okay, now let us go in and start our IHC test. So what all should you as a lab director or a lab manager or a chief pathologist should bother or know in your lab? So you need to know whether you need to go in for a manual or an automated type of processing for your IHC. You need to also have more awareness on the type of antibody selection that you're going to do, the assay optimizations of your antibodies, the antibody validation methods, and finally selection of your controls. Obviously all this is going to lead to a lot of headache, but you need to evaluate each one carefully before you actually jump into setting up your IHCs. So selection of automated platform, you need to give it a lot of thought. Definitely, these are going to be costly. It is going to increase your cost per test when compared to your manual methods. You should also know the user friendliness of these equipments. The capacity is something that you need to analyze and understand. For a starting lab, I would always recommend start manually and then progress gradually once you start adding your various antibody panels, and then move in once you have a good workload, work volume, then you progress towards an automated platform. You also need to know the turnaround time, because some of these tests are there on your instruments and they go up to anywhere between 8 to 12 hours as well. These are for few high-end labs which are doing the high-end tests. The amount of reagent and antibody used, definitely we are in India, and it is not that we are able to adopt all the Western practices or the textbook methods, but definitely we need to here give a lot of thought towards a good lab practice, and we need to see that there is no quality compromise on the amount of reagent or the antibody that has to be used. You also need to assess these automated platforms in terms of how much antibody consumption is going to happen, because many of these antibodies are expensive. Also, you need to know the local waste disposal controls, because there's going to be a lot of waste generated from these instruments. And finally, the quality of the stains that are going to be generated out of these equipments. You also need to know that you need to have a forethought on, okay, now this is my work volume, this is how it is going to have an annual increase, and these are the test requests that may come from my clinicians. And also you need to see that and have a forethought and seeing that you will be your instruments will be capable of having multiplex runs and also in situ hybridizations. We In fact, we have recently started a Brightfield Insight to hybridization in our own laboratory, and we are in the process of validation. So you need to know that your automated platform is capable of handling these complex tests as well, and not just basic IHC testing. And the last but not the least will be whether these automated platforms can be integrated with your lab information system. Simple thing as generating a barcode and then integrating the same, because we need to reduce the errors. And please note that all these automated equipments have a barcode reader, and they will be able to dispense the antigens and the antibodies, the secondary kit, etc. on based on the barcode that is being read by the instrument. Now, coming to antibody selection. So you need to know I would recommend start small. So you need to see what kind of cases are you getting in your lab. Is it a lot of malignancies where you have a lot of round cell tumors, or is it cases of breast cancers or prostate cancers or GI cancer? So based on this, you need to know the clinical application of why do I need this antibody, and you have to have the understanding of what is the diagnostic sensitivity and specificity of this antibody, whether the test volume is significant to procure this antibody. A clinician may come and tell, okay, now from tomorrow, please start H. pylori detection on IHC. But are you having so many number of cases that you are going to be able to justify to your management that, okay, now the test volume is significant where I can procure this antibody, and within a year I'm going to use the entire antibody volume. So this is something that you need to give it a thought. If it is going to be just 1 or 2 tests a year, obviously it does not make sense in procuring that antibody. The next question is, where do I get this antibody? So you have to have an idea of procurement of these antibodies, because the IHC market is flooded with a lot of clones and a lot of vendors who keep coming and troubling you. Okay, now this is what we have, this is what we are offering, this is the latest antibody. There are so many new antibodies that are being available in the market now, but you need to know which are part of your screening panel, which are going to be part of your confirmatory panels, and whether you are going to have a costing on these and a different type of costing on the screening and the confirmatory markers. So how do you know and select the best clone? This is something which is very, very important, because choosing the best clone matters for the end result of your correct and accurate reports. Otherwise, you're going to be in a lot of trouble, especially so for your screening panel itself. Will it work with my test method? This is something that you need to understand. Few antibodies work well on manual IHCs, few on the automated platforms. I wouldn't say that there is any lab which cannot have a backup of manual, because when you have a large panel of antibodies, we work with both automated and manual systems, automated or semi-automated and manual methods. So I don't think there is any lab which can confidently say, okay, I'm 100% automated. It is just not possible, because you have to rely on, during your process of standardization itself, many antibodies may not work on your automated platforms, and you need to go back and see and change the buffers, your incubation times, etc. on your manual tests. Whether you use concentrated or ready to use antibody. Now, what do we mean by concentrated antibodies? These are low volume, it's very low volume antibody that you require, but at very high concentration. And then you're going to dilute these, aliquot it, and keep it and use it for your tests. Or are you going to use ready to use? Ready to use is something where you need not dilute these antibodies, and they are prepared at optimal dilution, and then you can directly put them on your slides. So you need to give a thought to this, because the costing is going to be different on your concentrated and ready to use antibodies. And you need to also see your test volumes when you figure out whether at what concentration you're going to use, and how many tests can be performed with that particular concentration. So when there is a very high volume, generally the concentrated antibodies work well rather than ready to use antibodies. So ready to use antibodies, you may get them in volumes like 3 ml, 6 ml, 12 ml, etc. So based on your test requirement and volume, you need to decide. The last but not the least, can my lab generate positive controls for this antibody? As I said, there are few rare antibodies for which controls may not be readily available, and you need to know and maybe even try getting some cell lines as well. A little bit on the positive controls, I'll be taking it up during the last part of my session. This is the most important part of the discussion. Now, what are the records that you need to maintain? First of all, you need to have good sample accession register. That is what I mentioned in my first few slides. The cold ischemic time, pH of your formalin is very important, because you cannot have very underfixed tissues out here, or concentrated formalin, which is going to cause harm to the IHC result. Record of reagent change in your tissue processor should be maintained. Then the calibration records of the pH meter, that will be mainly for your manual procedures, and also your instrument maintenance and calibration records. So here preventive maintenance is something that you need to do when you have your automated platforms, and you need to day on day keep assessing your controls, because and also have IHC audits. Otherwise you are going to be in trouble on this. And also you need to have a very good audit trail of your positive and negative control blocks that you're going to generate in the lab. This is always a good practice, because there are some controls Like for example, you may have a gist positive case today, CD117 positive gist and a dong1 positive gist. Now you want to retain this for your control. Which block, which is the case number, all this has to go as part of your audit trail, and it should be a controlled audit book, audit log that you need to have in your lab. So let's come to antibody optimization and troubleshooting. So once you have recognized an appropriate positive control, you need to check the pack insert and accordingly set up your retrieval method, whether what kind of buffer that you're going to use, and the primary antibody incubation time. Generally, the primary antibody incubation time can vary anywhere between 10 minutes to even 60 minutes to 120 minutes. It depends on how you have standardized and what is the type of antibody that you have used. Let's come to different scenarios. Now look at this. You have ordered a new ER in the lab. So you have strong staining without any background. Look at this, no background noise. You can clearly see your stromal cells and all the nuclei have taken up the staining. That means this is an antibody that is going to work well in the lab. But you have strong staining with weak background. So there you need to know that you need to use an effective block. The blocking agent may not be really satisfactory, or the other cause could be that you have to reduce the concentration of your primary antibody if you have used a concentrated antibody and not a ready to use. So what happens when the antibody concentration is higher, then it can cause a lot of non-specific background reaction as well. Or you may need to reduce the incubation time of your primary antibody. When we have strong staining with strong background, again, it may be due to the ineffective blocking agent, or again, you need to reduce the concentration of your primary antibody. So these are some scenarios and how you troubleshoot it. The next scenario is, when do you know that the antibody will work, but with a little bit of tuning? So this is how you can see compared to the other case. You can see lesser number of cells have stained here, and it is a weaker stain. So when compared to the strong nuclear stain that you had seen in the last slide. So here you need to understand that there is weak staining signal but no background. That means your blocking is effective, but you may need to work on fine tuning your antibody incubation time or your concentration. Or you may altogether need to use a different detection system, or you need to try a different retrieval time. So maybe you have done a retrieval for 30 minutes. You may need to do the retrieval timing for up to 60 minutes. So something of this nature you will have to standardize based on what is the kind of signal intensity you're seeing. Same thing for your weak signal staining and weak background. Again, you have a background, that means even your blocking agent is not effective, and then you need to continue your assay optimization. When do you know that the antibody will not work at all? So you procured an antibody, you really have not gone through which clone you should use or whether it can be performed on your instrument or not. So then there is absolutely no staining signal or no background on your control tissue. Or there is a weak background, but definitely no staining signal at all. So what you need to do is, maybe the doubt will be whether you've actually added the antibody or not. That also could be an issue. So you need to repeat the steps carefully, including when you're doing a manual stain. Please check the pH of your buffer, which is very important, and whether that pH is suitable for that particular antibody. Many antibodies will work with alkaline pH, few with acidic pH. So you need to go to the pack insert or the literature from you where you have taken the antibody for your test. And then you need to rework on your primary antibody concentration and incubation time. Please note that this particular scenario will have lot of variables. Try to remove one variable at a time and don't try to attack all variables at a time. You need to be patient. So you need to do attack one variable today, tomorrow another variable, and so forth. So like till you arrive at the what step has the error happened. So this is what you need to know, and that is how you are going to standardize the antibody in your lab. Look at this. This is an image that I wanted to show. Recently, we had a nuclear antibody which just did not work. So you can see that this is the fallopian tube lining. This is a nuclear antibody. So this was for WT1 actually. And you can see that very occasional cells were staining in our first protocol. Now we come to our second protocol. We can see a lot more brown staining happening, but still not so satisfactory. So here what we did, we applied 3 protocols at one go. So this was with one particular detection kit. This was with one particular detection kit. Now this second detection kit, we also did a third test. Look at the dab intense staining that we are seeing with an amplification. So an amplification kit is generally going to cause or enhance the signal intensity, but this can be harmful. Why is it? Look at this stroma. The stroma is actually not supposed to take up the staining. The localization has gone beyond the native cells, which actually has to take up the staining into the surrounding stroma. This is not something that we require because we are going to have an overcall in our cases. So what did we do? We went back to the second step without the amplification with a different kit, and then we increased the antibody incubation time where we did not have any localization seen in the stroma, and it was very specific to the epithelial lining. So this is how you need to know and select your controls as well. Say for example, now here for this particular case, if I had taken a known positive like a serous carcinoma of the ovary, which generally shows a very strong WT1 staining, if I'd used that strong expressor, I would have got the result in this very first place. But what about low expressors? We may have tumors which don't, which are showing low expression levels. That will be missed out when you take your strong positive controls. So generally for this particular antibody, fallopian tube is an ideal control, and that is how you are going to assay optimize it based on multiple factors that are available. So this definitely is going to be an overcall, especially when the we are seeing cases with actually weak expression, they're going to overexpress. This is just for one particular case that I'm seeing. Now coming to new antibody validation. This is something that all of us should be aware of in our lab. We need to have a proper SOP. We need to know that for FDA approved kits, it's going to be 20 positive and 20 negative tests. For LDT or lab derived tests, it is going to be 40 positive and 40 negative tests. These are generally for your predictive assays, like for your example, ERPR HER2. And these are some things which are theranostic markers, and you need to have a proper protocol and you need to have a threshold which already ASCO-CAP has defined. So for your negative cases, it is going to be more than 95%, and your positive case is going to be more than 90%. So this is what you are going to use. When it is an FDA approved test, you're basically verifying. On LDT, you're actually doing a complete validation. For your non-predictive assays, also generally ideal recommendation is we do something like 40 positive or 40 negative, but it may not be always possible. So we try to settle for a good number of cases with at least 10 known positives and 10 known negatives. And for your concentrated antibodies, other than this, you also need to dilute the antibody at various concentrations, like it could be 1 in 15, 1 in 20, 1 in 40, 1 in 60. So these multiple dilutions have to be tried with generally a low expressor control and see where it is going to pick up, and then put up your protocol recommendation for that in your lab. So you may say that, okay, now 20 positive negative, it's going to be very expensive. The best thing is to have punches like these or your microarray type of blocks that you can make. And then see, look at this. We almost have 10 sections in eight sections in each of them, along with your known positive controls in all of them. So there is still space, and especially your automated platforms have the ability to dispense the antibody throughout your slide. So you can have your microarrays generated, and then you can validate your antibodies, your new antibodies in this manner. You also need to simultaneously validate on cell blocks and also on decalcified tissues. So coming to your reagent validation, this is another very important aspect. You need to have reagent validations. When do you do your reagent validation? So this is for your new reagent lot. It could be either your primary antibody or your secondary kit. You need to have one positive and one negative and compare it with your old reagent lot. And also when there is change in your vendor, clone, incubation time, or your retrieval time, especially when there is change in your clone, you need to do a proper validation of again your 20 positives and 20 negatives. So clone is something that is going to be very important, and you need to go back to this previous slide when there is a clone change completely. So you may be using one Ki67 clone, and then after a year you may want to change. You need to go back to this protocol of validation. See, the other things are like, for example, your location of your lab or your, again, manual to automated. You need to run all your antibodies which you were done in doing manually when you get your automated platform, because there are going to be variations between your manual and automated, and the incubation times are going to change or your retrieval methods may change. Hence, you need to, if you have 20 antibodies in the lab, 20 you're going to want to shift to automated, you need to revalidate all of them on your new platform. Post expiry antibody validation is something which is very important. These are precious antibodies. We don't want to throw away these antibodies, but it is always better that, though the NABL recommendation is that they do not allow usage of any post expiry reagents in the lab, but however, I think IHC antibodies are allowed, and the recommendation in 112 is also that we validate the post expiry antibodies at least once in 6 months. You need to have a proper record on this. You need to use a known positive and negative control. You need to record the results of it, whether it is satisfactory or not. If it is not working, it has to be discarded, and the same has to be mentioned in your record. Your QC records, daily QC records are something that is very important. You need to use positive controls on every slide. There is no more batch control. Earlier for manual assays also they were using batch controls, but it is no more the recommendation. Even for your manual assays or your automated assays, please use positive control on each and every slide. And the control should have comments, your control record documentation should have intensity, localization. These 2 points have to be mentioned. So what is the control you have used? Whether you have used an equivocal control for your HER2, or you have used a low expressor control for your S100. It really will not matter, but the same control documentation has to be there, and the intensity of staining and where the localization is there has to be mentioned, and also a comment on background staining. If the control is not as expected, then you need to do a root cause analysis. Kappa has to be done for each and every case. Now, there may be instances where your technician has put a wrong control. For example, it is an S100 and they have taken a control with a leiomyoma. We all know that unless there is some nerve tissue there, it is not going to take up any staining. So these are instances where you need to record it, and then you need to have a root cause analysis, and this is where your control audit books is going to come into picture, where the technician can have a good handover of what control has to be used for which antibody. Few quality improvement processes, peer review of your old archived IHC slides is very important. You need to enroll into interlab comparison programs or EQA. EQA is going to be expensive. These can be national or international. Earlier, we used to have international programs. Now we have quite a few national programs that are available for IHCs as well. So these EQA programs, generally they have breast modules and they have general modules. So you can enroll depending on what antibodies you're running in your lab. An IHC audit has to be done, especially for your breast cancer cases, where you need to see and audit how many ER positives, how many HER2 positives, and how many triple negatives were there in your lab. So this will give you an overcall or undercall of your results and whether it is working well or not. Here for HER2, you can also have reflex tests. Your ALK is another antibody where you have reflex test. Your ROS1 IHC is something that you have a reflex test. So here you can correlate all your IHC results with your FISH results as well, and then have a documentation saying that it has worked properly. So your 3 plus should correspond to a positive result on your FISH, and an equivocal, depending on what is the FISH result, also should come into picture. So this is what a good IHC report is going to encompass: your demographic details, sample information type, type of fixator, what is the duration of fixation, cold ischemic time. Your primary tissue diagnosis is very important because you need to know what, and like a round cell tumor. Now, what are the antibodies that you put up? You may have 2 or 3 different blocks. Now, in one you may have a leiomyosarcoma, in one you may have an osteosarcoma like area. So whether it is a tumor which is de-differentiated, now which is the block that you have selected, and what is a cytobiopsy with your IHC findings. Also, it is good to mention the clone of the antibody, whether it is manual or automated processing you have done, then details on your internal and external quality controls. So that have been put up on the slide. And also you can put an additional comment, like for example, you have a double expressor on your NHL, a high grade lymphoma, you have BCL2 c-MYC expression or something like that, and you have advice for a FISH gene rearrangement study. So these kind of advisories have to be put up in your reports. Let me just take you all through one interesting case just to break the monotony. We have a 45-year-old male who presented with iliac and sacral lytic lesions. So please remember, this is a bone lesion. So this is how the histomorphology looked. So as all of you can see, they're definitely round cells, a little pink, a little blue, and then we have the fat spaces out here, and we have crush artifacts to the corner here. And look at these, the cells look quite large, and there are a good number of neutrophils as well, which are scattered throughout. So okay, we thought, okay, this is a hematolymphoid neoplasm. We checked on the CBC. CBC reports were normal. And based on our thing of malignancy, the PET was done for the patient, but there were no obvious PET lesions except for the sacral iliac uptake that was there. So what did we do? We started with the initial screening panel. Now this is called as the initial screening panel. For an undifferentiated malignancy, we always put up a hematolymphoid marker, an epithelial marker, and a mesenchymal marker. If it's a young patient, we also put up a germ cell marker, which is nothing but SAL4. So here we have done S100, CK, and CD45, all were negative. Please remember, the screening panel generally consists of these four: germ cell, S100 for either your melanoma or mesenchymal, CK for your epithelial, CD45 for your hematolymphoid. There is no tumor generally which will not take up one of these. There are a few exceptions to the rule. There are about 14 or 20 odd tumors which can be all triple negative. So this is what is called as a triple negative condition, and this you need to be concerned about. So what did we do? We did a CD138. So plasmablastic lymphomas, we know, because we were still thinking of a hematolymphoid neoplasm. So, but plasmablastic lymphomas we know can be CD45 negative. So CD138 came negative. KI was very high. It was highly proliferative tumor. Because the clinician was insisting, no, this has to be a primary bone tumor, we also thought whether this could be something like a Ewing's sarcoma family of tumors. So CD99 was positive. What did we do? CD99 is generally a screening marker which can be positive in hematolymphoid as well as in your soft tissues. We did NKX 2.2. NKX 2.2 is a confirmatory marker for your Ewing sarcoma, but NKX 2.2 came negative. It was definitely concerning. Look at this. What did we do then? We have nice membranous staining here. So we did a TDT. TDT highlighted all the tumor cells. That means we were dealing with a lymphoblastic lymphoma. So CD117, MPO, Desmin, 34, cyclin D1, etc. were also put, but which were all negative. Then we did the lineage markers. So here we have CD20, which is positive, 3 negative, and 10 positive. So what was this called as? This was called as a B cell lymphoblastic lymphoma, primary of the bone, because CBC was normal and there were no other lesions. So this is how you go from your screening markers to your confirmatory markers. You cannot be putting up all the tissues at once. So one more thing that you need to remember is, because IHC is going to be expensive for the patient, we cannot and also we cannot have repeat biopsies. These are the days of core needle biopsies. You need to always see that the cores have to be put in multiple cassettes and not just in one cassette, because you need to have one cassette for your IHC and one more maybe for your molecular test. So you need to preserve some amount of the tissues. Sometimes we may run into 14 to 15 markers as well, and you need to have adequate tissue for all your markers. Now let's move on to the most important aspect. Food for thought. This were the international results of IHC PT program. You can see that 34% of the labs had optimum results, 33% good results, but whereas one third equally failed. So why is there failure of so many labs in the PT programs? This is because there is wrong selection of positive controls with tissues that show a high expression levels of the antigen of interest. This I've been telling in my previous slides also. Please do not select tissues that show very high expression levels of antigen. Why do we need to standardize the controls? I said failure of the program itself is one point. Now, we need to know whether the proper antibody was applied or not. So you need to know that, look here, this is a case of a neural tumor, and then if you're doing a SOX10, you're taking the appropriate control and not some, you cannot take a fibroid for SOX10 to be expressed. Please remember that. So you need to know that the proper antibody was applied. If your positive control itself comes negative, how do you even know that the control has been applied or not? And also for achievement of your technical sensitivity and specificity, it determines the reproducibility of the test. So this is where we fail in our PT programs if we do not have appropriate controls which are standardized for our assays. And also it is basically indicating transfer of the test methodology from literature to the lab. Let's come to few concepts, that is internal control and external positive control. What do we mean by internal control? These are cells or tissues which are expected to be positive in the patient sample. For example, you have a carcinoma of the breast. Look at this. These are areas of DCIS and this is the internal control, which is ER. Now there is ER expression in the internal control, so I'm happy. Whereas the test is negative, that is the DCIS area is negative. So here I'm able to confidently tell the clinician, look here, this DCIS is ER negative. Now it still will not matter whether the external positive control which I've taken in my slide is positive or not. I really need to see whether this ER has taken up the staining or not. Why is it? This is because if there was absence of the ER staining in the benign tissue, that means there has been a primary fixation issue in my test issue. So that means we are indicating a false negative result. So when your ER does not take up in your internal control, you definitely need to repeat the test or choose another block where the tissue has been processed and fixed properly. Look at the slide down below. This again the DCIS P63 is positive. So here we know that it could be a case of invasive carcinoma. P63 being positive around the areas of DCIS or around your benign ducts is a good indicator that the internal control has worked well. So it determines if the test was actually successful or not on the test tissue, and also it determines few of the pre-analytical and analytical components of your test. But is internal control alone enough? Definitely not, because it does not identify the point of failure. So you need to know that internal control can be and made can be made necessary in few instances. Like you always, like for example, your MMR studies, you need to have tumor tissue along with your benign colonic mucosa, which is taken for your MMR testing on your colorectal cancers, so that we know in case there is absence of MLH1. So it has to be still retained in your benign cells in the native tissue. So that is how you need to know that internal controls are necessary. And few other examples are your P10 and SMAD4, where the benign tissue, all your normal tissues should take up your SMAD4 staining. All right, so it is only the tumor which where there is going to be loss of expression. This is similar to like your INI1 expression and loss. All right, whenever there's INI loss, that is when you need to say, okay, there is loss of expression. But how confident are you in calling this a loss of expression? You need to see and observe around the benign areas where they take up the staining. So these are areas where your internal controls are definitely necessary. We come to external positive control. These are positive control tissues that are not part of the patient sample. Although I was telling, now the test tissue had some benign areas which can take up. Now this is another tissue that you're going to put on the same slide. So these are already known positive controls. And generally, we utilize our own lab resources to generate these external positive controls. Some labs may even use cell lines, and they may prepare cell lines to use the external positive control. This controls the analytical components of the test, and the result should be like your internal control, where there should be some amount of expression. If the internal control fails, okay, so you have an ER case where the DCIS is negative, the internal control benign ducts are negative, but your external control has taken up the staining. That means your test has passed, but your test tissue, there has been a failure. So and that is what it is indicative of. But whereas when your internal control fails, we really cannot know where it has failed, whether the antibody has actually been applied or not, whether the secondary kit has been dispensed or not, whether DAB has been applied or not. These are some things which we will not be able to say with just the internal control being there. So most of your cases, try as far as possible to have a good internal control as well as an external positive control. I'll introduce you to few new concepts in IHC called as sensitivity and specificity. We all know that these are predominantly employed in the biochemistry and hematology labs, but here in IHC labs also we have this. So here we have something called as technical sensitivity and specificity, diagnostic and clinical. So all three are different. How are they going to differ? Now your technical sensitivity and specificity is predominantly in your analytical area. Here we know that high sensitivity will be for antibodies which can detect low levels of expression even at very high dilutions. That means it is very sensitive. And high specificity, we know that these antibodies are able to detect the target analyte only. For example, you have like how I mentioned to you earlier that if ALK. Now in ALK expression, we know that at very high dilutions, only the ganglion cells of the appendix will take up and no other cells will take up when we are using something like appendix as the control. All right. So, but the same ALK can be a specific target analyte when we are using it for an ALCL test. We know what is how it is going to work on the control and how it is going to be specific on the test tissue. So this is how we know that something is called sensitive and something is called specific based on the analytical ability of the antibody. Coming to diagnostic sensitivity specificity, it is going to differ a little. It is based on the practical utility. These are nothing but your screening and confirmatory markers. For example, S100 is a sensitive test for melanoma. But is it going to stain only for melanoma? No, it is also going to stain for your any of your neural crest derivative tumors. Like for example, your peripheral nerve sheath tumors, they're going to take up S100. MPNST is going to stain for S100. Now, will you be able to differentiate whether it is melanoma or whether it is MPNST by S100? No, it is sensitive as a screening parameter, but not specific. Now, what is specific for melanoma? It is going to be obviously your melan-A or MART1 or your HMB45. Those are your specific markers based on the clinical utility. Same thing, for example, DOG1. DOG1 is specific for your GIST. ERG is very specific for your endothelial marker. So these are going to be specific and not sensitive, whereas all your screening panels are going to be sensitive. Now coming to the last, clinical and sensitivity and specificity, these are applicable mainly for your companion diagnostics. Today, this is out of my purview to talk on companion diagnostics. These are especially for all your biomarker related, where a particular drug is developed, is used for treatment based on the clone which is used on a particular platform. So here comes in the clinical sensitivity and specificity of the test. I'm introducing you to one more new term called as ICAPC. This is nothing but IHC critical assay performance control. These are actually gold standard. And in fact, I've taken this out of a paper which was published, I think in 2015 or 17 on standardization of positive controls. So this is basically by the Nordic people who have written and come up with a standard protocol for few of the antibodies wherein we can use these critical assay performance controls. So here they've used tissues which are negative for the particular antibody, weak and strong expressors. And for example, now the same thing if we apply. Now ASCO CAP guideline recommendation for your ER control is cervix. Many people I have seen they use either fibroadenomas or benign breast tissues, and some people even use very strong Aldrich score 8 for breast carcinoma cases, which should not be ideally used. When you're doing standardization of your ER, you need to use cervix. You can see that the ectocervix shows some basal staining out here, and the stromal cells of the cervix also shows, and here endocervical lining also shows some expression. But when it comes to tonsil, it shows very low level of expression in occasional cells in the surface epithelial lining. So this is how you're going to standardize for your ER control. So you have a low expressor and you have a moderately high expressor for your ER. Then you have your PR control. Look at this. It is going to differ a lot from your ER because the ectocervical lining should not show any control post expression, and here only the stromal cells and your endocervical cells will show expression of your PR. Tonsil absolutely nil expression. So when you are doing your assay optimization, this is how you're going to standardize for your ER control. So you have a tonsil absolutely nil expression. So when you are doing your assay optimization, this is how you're going to use the controls for your ER control. Tonsil absolutely nil expression. So when you are doing your assay optimization, this is how you're going to use the controls for your ER control. Coming to the specificity and sensitivity, this is going to help you, and then maybe you'll need to tweak a little bit of your antibody incubation time for these PR antibodies. So that is how you'll know that after some days you may see some variation in the staining pattern. So this is how you're going to catch the staining, different staining patterns based on your control assessment on a day-to-day basis. This is a commonly asked question to me. I take up few classes for the PDL1 um, um, interpretations. So for PDL1 control, we use tonsil as the positive control. Here we see that the crypt epithelium shows a strong expression, whereas your follicular macrophages are going to show a very dim expression. So we have lower limit of detection or your LLOD coming into picture and the high level of expression. So in one single tissue, you know how your assay has been standardized. Let's come to few other scenarios. This is for pancytokeratin. Look at this appendix. All the cells are taking up. Your lymphoid follicles are not taking up. The liver shows majority of the hepatocytes being stained with this, whereas in your tonsil, the surface epithelium and crypt show staining. Again, your lymphoid cells do not take up. So there is nil staining. So this is how your pan-cytokeratin is standardized. Because I see many times if you have not done this amount of standardization, cytokeratin can show very non-specific staining, and there can be a misinterpretation of your or an overcall of your carcinomas in cases, because sometimes it does take up in stromal cells, and then you may call something as a metastatic carcinoma. So please be aware of that. And when you are using or introducing cytokeratin in your lab, please use these as your assay standardization controls. Look at CK20. Appendix is taken up here, and there's a very good staining of the surface, but when it comes to the crypt lining, it is very dim expression. So you have high expression, low level of expression. Obviously, liver should not show any staining, and your tonsil also should not show any staining. So you have negative and positive. We have CK7. So this here, the liver is going to show all the bile ducts which take up staining. Then you have pancreas, which have taken up the staining in all the intercalated ducts, whereas your appendix should not show any staining. Please note CK7 is for your upper GI and your lung and your breast, but whereas CK20 is for your lower GI. So obviously here appendix should not show any staining for your CK7. If appendix shows any staining of your CK7, that means there has been either a longer time of retrieval on this or a longer incubation time of your primary antibody, and you'll need to work on both these. Look at TTF1. With good clones, all the thyroid follicular cells take up strong nuclear staining. And look at the lung. These are all benign tissues, if you notice. These are bronchial epithelial cells here, and which show a weak expression, and tonsil will be negative. We have CDX2. CDX2 will show strong nuclear expression in appendix. Why have we taken appendix? We all know that CDX2 again can be used either for your upper GI or for your lower GI tumors. Now the confirmatory marker for your lower GI obviously is your SATB2. So here you can see pancreas where the intercalated ducts show weak to moderate nuclear staining. So this is low level of expression. This is high level of expression. This is complete negative. Look at Desmin. Desmin, we have appendix where all the smooth muscle cells should take up the staining along with the smooth muscle of your capillaries or your blood vessels here. Liver will be completely nil, and tonsil, obviously the blood vessels around the smooth muscle around the blood vessels will take up the staining. So this again will have low and high levels of detection. CD3 antibody, tonsil, all your T cells should take up staining. Look at appendix. Your lamina propria, the interfollicular dispersed cells will take up staining. Look at the liver. How many cells take up staining? They have very few. So this is how you are going to set up your CD3 assay. For CD20, it will be slightly different. We know that tonsil again here and your appendix. Appendix will be fewer number of cells. We all know that it is going to be CD3 more than CD20 in a reactive condition. And again, these are benign tissues. And here you can see that the liver, very distinct staining is seen in only few of the lymphoid cells which are seen in the portal tracts. Otherwise, in between the sinusoids, there should be no uptake in a benign liver tissue. So that is again on your LLOD. Look at Ki67. You have the germinal center cells, B cells of your tonsil, which all of them take up, and a strong staining that has happened. In appendix, you have the proliferating crypt epithelial cells which have taken up the staining. And in liver, other than your granulocytes, nothing else. So it should be that there should be no staining in a benign liver tissue, and you may say some granulocyte staining. Then your S100, you have tonsil with your dispersed follicular dendritic cells, so which show some strong staining out here. And then you have your pancreas where your islet cells take up. And here you see the intensity of staining, it is very moderate to low expression. And liver, no staining in the hepatocytes, and some staining in the bile duct epithelial cells may sometimes be seen. For chromogranin, you need to use pancreas. All your islet cells should be highlighted. And appendix, your ganglion cells can show some staining, whereas in liver, there'll be complete negative staining. Synaptophysin will be similar to your chromogranin. Here we have appendix where ganglion cells and axons of your Auerbach's plexus will take up. And also here you can see that in the pancreas, the islet cells take up strong synaptophysin staining. Whereas in the liver, there should be no staining, but only some nerve bundles, in case they are seen, they can take up the staining. I have seen many of the people using very strong chromogranin and synaptophysin controls. This again is going to miss out your low expression test tissues. So where do we actually use these ICAPCs that I showed you? Generally, these can be used for new protocol development, and you can use them as daily positive controls also. And also you can use them for EQA IHC proficiency testing. Generally, the international EQA program organizers, they also ask for your daily controls, what you are going to use on your slide, and the same has to be cut and sent to them with staining. So at that time, you can use this, and it is an indication as to how you have standardized the assay. If you use this, you may ask me how easy or difficult it is to get these positive controls. I'm talking about low expression. Definitely, it is not so difficult. If you are a lab which is doing a good amount of histopath work, then obviously these benign tissues should be available in your lab, like your tonsil, appendix, liver, and pancreas. If you have an array of these four tissues, benign tissues, you'll be able to run more than 100 antibodies easily without the requirement for any other known positive control or a strong positive control. Please remember, strong positive, I mean, positive controls where we actually use a known positive controls are like something like your EBV, so your CMV. So over there, we need to have these positive controls, and it has to be a known. Otherwise, normal tissues are not going to express. These are the cases. But otherwise, for most of your antibodies with an array of all these four tissues, you can definitely run most of your IHC tests. I think I've almost come. I have one last interesting case to discuss. So this is a case of a 39-year-old female patient. Uh, they were basically, the tissue was submitted with complaints of pain in the right iliac fossa. The ultrasound based on after the histom, that's all we were given actually, the first 2 points. Later on, we went and discussed, and we realized that the patient has a complex ovarian mass with ascites, and the patient also had some mild pleural effusion with presentation of the omental mass. So the true cut biopsy was actually done from the right iliac fossa omental mass. So this is the true cut biopsy that was submitted, has multiple fragments. Let's come to the histomorphology. We can see a lot of pink and blue cells out here, a lot more pink than blue. So something very low grade morphology that is happening. We can see that they are very uniform cells with small abundant cytoplasm out here. You can see that somewhere some cord like arrangement also is there. There are some proliferating blood vessels as well. You can see that there are areas where they are closely packed also. So we did some immunohistochemistry, thinking that okay, now whether it is something of ovarian origin, because it being a female patient, and the surgeon was very definite that it is a something arising from the ovary. So pan CK was positive. It was not really very high expression, but definitely it was positive in the cells. Here you can see that this is CK7, very dim highlighting of cells, but otherwise most of them being negative. This is a nuclear marker. What did we do? We did a Paxate. Paxate is a marker which is going to stain for your Mullerian origin, or it can be your renal origin, or it can even sometimes be present in mesothelial cells. So now Paxate being positive, we didn't know, okay, now this is something like a low grade tumor. Now Paxate is done whether it is still Mullerian origin or renal or something else. So that was on the thought process. So what did we do? We did a CD10 renal tumors or anything, though not really clear cell morphology, because Paxate came positive and it was not resembling any chromophobe or papillary or anything. But CD10 was negative. We also, because it was low grade morphology and good amount of cytoplasm, whether it could be neuroendocrine, but synaptophysin and chromogranin were negative. We did a WT1 because Paxate was positive. It helps in terms of either an ovarian serous type, again with low grade morphological features, or something mesothelial origin, but WT1 was negative. Now, Ki67 was done. This is definitely a low proliferative index with less than 5%. We were something dealing with something which was really low grade. So what did we go? Sometimes it is better that you go back to your histomorphology. So you can see that we went back to the histomorphology and saw some areas. You can see this nicely arranged cells around some proteinaceous material. Look at the high power. So we saw many of these cells out here, and look at the chromatin pattern, very low grade features. All right. Some had some cytoplasmic clearing. So these resembled thyroid follicles. So we put up a thyroglobulin, which was strongly positive. Then we also did a TTF1. So we went back and asked the surgeon whether this patient has any thyroid lesions or anything, but no positive history was given. Finally, we signed off this report since this was a right iliac fossa mass, that the neoplasm is showing expression of thyroid origin markers, and differential diagnosis whether it, because it is a complex cystic ovarian mass, whether it's a struma ovary or whether it's a metastatic follicular carcinoma. So we advise for a clinical radiological correlation. Unfortunately, the case was lost on follow-up. So many times you will need to get back to your histomorphology. IHC alone will not help you, and IHC may be confusing many times because there are going to be overlapping phenotypes. As I said, like for example, now GATA3. GATA3 is going to stain for your breast as well as your urothelial. So you need to be very, very strong on your histomorphology before you start ordering the panels. Never order a panel without seeing what the histomorphology is, whether it is spindle, whether it is epithelioid, whether it is anaplastic, whether it is round cell. So based on these morphological patterns, then you start ordering. And obviously you cannot do this without relevant clinical history. Go back, talk to your clinician before you start your IHC workup, see what the radiology is, see if any CTs, MRIs or PET CT has been done for the patient before you actually order the panel. So coming to the end of my discussion, some take home messages. IHC, we cannot do away with IHC. Histomorphology is important. IHC is going to add to the histomorphological diagnosis. It is going to increase the confidence of your reporting. We know that the recent WHO has come up with a lot of tumor variants, etc. And the clinician depends on us more than ever before for the proper diagnosis, for aiding the proper treatment. Start slow if you're a beginner with very few antibodies. Learn to understand your screening panels and your confirmatory panels. Understand the assay optimization by standardizing the controls. Controls is something that is very, very, very important. I will again and again keep stressing the fact, because lot of false negatives, false positives can occur if you're not using a correct and proper control. And you need to be very patient during validations, especially so for your concentrated antibodies. You need to attack one variable at a time and follow good lab practices at all times. Generate a good quality report. Thank you.
Thank you, Dr. Vidya. It was a very powerful, power-packed presentation. I had one question. What are the common NCs you have faced, Dr. Vidya, in your lab during the NABL audits?
Yeah, the most common thing I would say is regarding the post-expiry validations. Not really an NC, but you see, it is difficult, like especially for your validations and your validations of both your new antibodies as well as your post-expiry antibodies. Sorry to say this, sometimes we get assessors where they don't actually understand what happens in the IHC lab also. So sometimes you may have a very easy audit. Sometimes you may have an auditor who is actually an expertise. That is when the lab actually goes through good quality improvement programs. So otherwise the points become very futile. All right. So the kind of NCs that have been was on the positive controls, like the record book maintenance. So it's a very important thing, because as I said in my talk also, unless you have the positive control record, you'll not know which is being used. And we all know that attrition rates are very high. So you may have a technician moving out of your organization who was handling IHC. Then what do you do? So where do you go back? Where do you see these archives? All right, that is one thing. Second thing, there is no proper NABL protocol on the validation part of it. That is a missing point. So there is no like CAP has, RCPath has recommendations on how many positive controls, I mean positive test issues or negative test issues. Here we are trying to do it following a good lab practice. Okay, now we need to, this was actually told to me also by my assessor, that more number of tissues you're going to use, the less number of failures you're going to have in your later runs. That is a very valid point. So you need to arrive at that number. I would say for some very rare antibodies, like when especially we deal with a lot of oncology cases, like your ROS ones and everything, it is very difficult to procure. So I mean, get those positive controls. So on those times it may be difficult, and where we'll need to reduce the number of positive tissues. So these are few things. And the other one is on post expiry. It's a big controversy in any lab, but definitely assessors were impressed, and they have been happy if you show them the proper post expiry validation record, saying that this is what you have done and these are the antibodies that you have discarded. The moment that you know that few antibodies are going into post expiry, you also need to understand, okay, these are very underutilized in my lab. So you also need to raise that question to yourself and to your lab personnel, telling, do I actually require these? In fact, you can shelf off a few of these antibodies in your lab gradually over a period of time, but not always, because generally for histopathology, we do not know when the need is going to arise and which antibody we are going to use. So, but few assessors will be like, no, you cannot use. That is one thing. And the other is the scope of tests. When we are defining, they want us to put in all the scope. I mean, each antibody has a different um, method or whatever in the scope. So that has been one thing. Okay, that is agreed. And then next time when we are again revising our scope, we need to show those validation records. That is well understood. But now, during the period from one audit to the other audit, when we are introducing new antibodies, how do we manage? Because we cannot put up these antibodies as not being under the scope or being under the scope. So that is one difficult situation that we have come across during the audits. So each assessor has their own viewpoint, but agreed, these are all taken as points for improvement. But definitely would want to see more on the NABL 112, at least on handling and validating and lot to lot validation. So what we are going to come up as a committee, some recommendation, guideline recommendation has to be there now. It is time that we have it in our labs.
Point well taken. Any other comments from our participants, panelists? Yeah. Dr. Wasim Khatib has written, could you please recommend few good companies dealing with IHC registered antibodies?
I think I'll take this. I'll can share my mail ID on the chat box. I don't think it is appropriate to take any company names here, so I would not want to do that. You can either personally ping me or mail me. I'll definitely help you out on that.
Yeah. And Dr.
So I think first of all, the questions which are coming, or rather more than that, the chats are very exciting. So that we look forward to invite Madam for part 2. Yeah, provided we can take her time. And it has been an overwhelming response. If you look at the chat box, there are personal questions. People are asking for Madam's presentations. I'm sure it's a feast for people who are specialized into this. At the same time, I agree that taking company names and this, let it be a personal introduction with Madam. So that thank you, Madam, for really guiding us through this. And we look forward to interact with you again. Thank you.
Thank you, Dr. Aparna,
Thank you.
and thank you